Welcome everyone. Thank you for joining us today. Today we have Dr. Janet Pope. Dr. Pope is a professor of medicine and head of the Division of Rheumatology at the University of Western Ontario, the Schulich School of Medicine in London, Ontario. She has published over 500 peer-reviewed articles and mentored more than 125 trainees. Research expertise includes scleroderma, SLE, and RA. She has been inducted into the Canadian Academy of Health Sciences. And I just want to let everyone know that today's session is being recorded. And so just to let you know that that's what we're doing so that we can later on allow others who weren't able to join us today to then review it again. Thank you very much, Dr. Janet Pope.
Great, and thank you so much, Sharon, for this opportunity, and thank you for those who are attending live, and I understand many of these wonderful sessions will be recorded, so you'll have a chance to go back and look or spread the word. So I'm going to talk about all sorts of things, including the management and also best practices in interstitial lung disease, or what some of you know of the term pulmonary fibrosis, that is associated with a bunch of diseases in rheumatology, so connective tissue diseases, and they include a very broad range, and we will talk about that. In addition, if you have a question, if you sort of scroll around the bottom of your Zoom area, usually the bottom, sometimes the sidebar or the top, there's a question and answer box. There's also a chat box. So certainly feel free to ask questions in real time, and we'll leave time at the end for questions as well. So I'm just going to advance here.
Oh, you need to ask it. Oh, there you go.
Oh, there it is. Okay. So these are some of my disclosures. So I do consult for many companies. And at the end, we'll thank our sponsors for this great event. So really, I want to talk about developments and research, and also for treatment, but the screening and diagnosis of connective tissue diseases that have interstitial lung disease in them. So how do we understand if the interstitial lung disease is present, and we'd like to catch it early, and also how do we understand, is it actually progressing or not? Look at new advances and the future perspectives in the treatment in this area, and look at insights across specialties. So Dr. Charlene Fell has also kindly given me some of her slides that will be relevant because there's some Canadian data in there that helps us to understand really the magnitude of this problem in Canada. So in general, we think of interstitial lung disease as being several types. So the types some of you are very familiar with are the idiopathic pulmonary fibrosis, and that's in that major box in the center. But there's collagen vascular disease, or what we call connective tissue diseases like scleroderma, rheumatoid arthritis, and less so, but still important, inflammatory myositis, dermato or polymyositis, Sjogren's disease, and then some of these undifferentiated patients, and also lupus. Then there's ones from exposure, so people that have inhaled toxins to the lungs, often repeatedly. So farmer's lung is something that can happen. Bird fancier's lung. Then there's inhaling other things that you wouldn't want to inhale. So people may be in construction, inhaling asbestos or silica. There's also drugs that can cause it. So one of the bladder infection treatments, nitrofurantoin, also some chemotherapy or radiation, so people getting cancer treatments. There's idiopathic. There's ones related to sarcoidosis, which is very specific, and the treatment is very much directed if you have that diagnosis to sarcoidosis. And even when we talk about all these idiopathic pulmonary fibrosis, there's all sorts of subcategories. Then there's ones in the end, we're not sure what they are. All these tests have been done, and we come out saying, we can't really classify you, and we can't classify you, and you get a lung biopsy, and maybe we still can't classify you. So in a nutshell, there's a lot going on, but I'm going to concentrate on the first sidebar here, looking at the connective tissue diseases. And I am a rheumatologist, so they're the types of patients that I would see. Then these are actually Canadian data looking at the categories of patients coming into Canada and multiple sites and what kinds of interstitial lung disease they have. So this registry is called Canadian Registry for Pulmonary Fibrosis, or CARE Pulmonary Fibrosis. And you can see here that the connective tissue diseases comprise 40% of these over 2,500 patients. So this is a big chunk of what's going on in Canada with these pulmonary fibrosis patients. And of that, interstitial lung disease from scleroderma, overall of the 2,600 patients, was about 1 in 6. So though scleroderma is rare, it's only 2 in 10,000 patients. 1 in 6 patients in this registry that had pulmonary fibrosis come from scleroderma. And about half that, 8%, come from patients with rheumatoid arthritis. So these are really important if you look at the overall mix. Of course, a lot of patients have idiopathic pulmonary fibrosis, but you can see how many would have connective tissue disease associated. So I've talked a bit about scleroderma, and we call it systemic sclerosis, or it's sometimes called capital S, little c, or SSC. So systemic sclerosis. But it's easier to say scleroderma, and I will from here on in just say the word scleroderma. So scleroderma is really a triad of problems. It's an autoimmune disease, so it has autoantibodies. And so the autoimmunity is certainly present. And many of our patients with scleroderma who get lung disease have this antibody, SCL70, or also called SCL for scleroderma 70, or it's also called topoisomerase 1. But you can have bad lungs and scleroderma with pulmonary fibrosis and not have that antibody. So we could consider everybody with scleroderma is at risk. So most of our scleroderma patients have a positive ANA. And almost everyone with scleroderma has vascular problems. So the most common is Raynaud's, where you have spasm of the blood vessels of your fingers and you get spasm and your fingers go white, like in that picture, and then red and blue, or white, red, blue, or blue, white, red. So they go ischemic or white. And in scleroderma, often the Raynaud's is very complicated. You can have ulcers on your fingertips, or losing tufts, part of your fingertips, from this severe form of Raynaud's. We also have other vascular beds that have problems. So pulmonary arterial bed, or pulmonary arterial hypertension. The kidneys can have problems with it. But we're going to concentrate mostly on this talk about the relentless laying down of collagen causing fibrosis. And that could be on the skin, so tight skin or sclerodactyly, but also for the purposes of this talk, pulmonary fibrosis in the lungs. And it's very important because it's a leading cause of morbidity and mortality in our patients. So the statistics are, there's a question of the CARE Pulmonary Fibrosis, the Canadian Registry. So are the statistics related to 1 year? So what I can say is that the statistics would be cross-sectionally, so over a few years, but on any 1 year, the distribution of the patients would be the same, that about 40% of the patients in the pulmonary fibrosis Canadian registry would have connective tissue diseases. So it doesn't vary too much year by year. So I'm giving overall percents, but any year would look about the same. So great question, thank you. So these are some of my patients, and of course they've given permission, and you can see there are many faces and many hands of scleroderma. So the faces you can see here, the lack of wrinkling in the first face, where the skin is all kind of puffy and starting to scar up. But then as the scars kind of change over time, or the thickening, the fibrosis, you can see the other patient here with their eyes closed has lots of red vascular change, or telangiectasia, lots of wrinkling around her mouth, which is because as the some of the thickening changes, you still have collagen laid down around where you would get normal wrinkles. You can see the hand at the top middle has lots of these red blood vessels, so telangiectasia, and that's some of the vascular change, and that can increase with disease duration. Then on the bottom panel, you can see hands that are puffy and actually pigmented. You can see hands that go into a more severe fibrosis or collagen being laid down or scarring, so people can't open and close their hands fully. You can see the next panel has a patient with also an overlap of scleroderma and rheumatoid arthritis, and you can see very severe deforming hands in the last panel. So these are real patients of mine that did volunteer that we could use their pictures. So it can look quite different. So we have presented these data and have submitted them for publication. And this is really looking at the prevalence of scleroderma in Ontario. And we're looking year by year. I'm just going backwards here, I think, trying to go back. Looking year by year, and the prevalence is indeed about 2 in 10,000. And when we look at these patients year by year, I'm just trying to go back, the incidence is about the same year after year. The prevalence is about 2 in 10,000. And about 15% of those patients will have very severe lung disease. So I'm going to now look at a patient. So this is a made up case, but it gives us an idea of types of patients that we see. So this is a man with scleroderma. Scleroderma is about 80% women, about 20% men. And so a lot of autoimmune diseases in rheumatology are more common in women than men. For idiopathic pulmonary fibrosis, that's not the case. It's a bit more common in men than women. So this is a man, 54 years old, non-smoker, not too much going on in his past history. He had mild type 2 diabetes, was on just a pill for controlling his blood sugar. In 2018, he developed quite significant scleroderma, the diffuse subset, which is a lot of skin involvement, fingers, hands, going up the arms, upper legs, and or truncal, in addition to the lower legs and lower hands, hands and fingers. He had a high skin involvement of how much thickening was on the skin. He did, when we listened, had bilateral, both sides, crackles on his lungs to about the mid zones of both the lungs. So when we listened to him, and he had been short of breath for about 6 months. Sharon, I might need you. There we go. Okay. So when we saw this patient, we would ask my colleagues, how often would you actually screen a patient? And when we have a person with scleroderma, 25% of them have interstitial lung disease, and 15% of all of scleroderma patients have bad interstitial lung disease. So we might screen a patient with breathing tests only if they're symptomatic. No one would screen every month. It wouldn't be feasible. People would screen at baseline or maybe annually. In early diffuse patients like this, we would screen probably even every 6 months. It's interesting. I wonder if we're on a timer or something, but that's okay. Once a year or never. And when I would ask my colleagues things like that, we would have variable answers, but at least every year after baseline. And for many patients in this early diffuse subset, especially if they had that antibody that's associated with getting interstitial lung disease, many of the colleagues would say every 6 months. But there's not consensus, and that's why I'm showing you kind of a range. And when we look at John, our fictitious patient, this is a real patient's lungs with, you can see the change at the bottom. And we call that honeycombing because you can look like Swiss cheese or honeycombs at the very bottom of the lungs. And you can see, so there's actually scarring. And in this patient, there might be scarring and inflammation. And that's important because it might affect how we might treat a person like this with scleroderma. So how bad is interstitial lung disease? How common in patients in Ontario? So this is looking at all patients in Ontario that we thought had systemic sclerosis. And looking here, you can see that the numbers are higher in the 51 to 64-year-old category of the incidence every year. And in fact, the numbers would be somewhat the highest in the groups that are 30 to 50, higher even 51 to 54 years old, and almost as high in the group who is over 65. So this is especially people over the age of 50. And just to remember, pulmonary fibrosis is especially people over the ages of 55 or 65. And because scleroderma is more common in women, this is hitting women more than men, but men who have scleroderma have a higher chance of lung disease, but 80% of people with scleroderma are women. So we have the 15% rule, and that's important for teaching my colleagues and even the medical students, general internists, respirologists, rheumatologists, cardiologists, nephrologists, GI doctors, teaching various specialists how common the complications are in scleroderma. So pretty much everyone has Raynaud's, and almost everyone has dysmotility of their swallowing tube, giving dysphagia or problem swallowing, and almost everyone has acid reflux. So a lot of people can have acid reflux, but it's more common and more severe in scleroderma because they're laying down a collagen on the actual swallowing tubes, the muscle, and also the nerves that coordinate the swallowing. So the swallowing can be discoordinated, and at the bottom of your swallowing tube, that valve can be scarred, so inappropriately open, so acid can come right up into your swallowing tube. So 80% or more have esophageal dysmotility and or problem swallowing, or what we call dysphagia. Half our patients will ever have had a finger ulcer on their tips, or where they have flexion changes and areas that have thinning of the skin after the skin has been thickened or fibrotic. So half ever will have a digital ulcer or a finger ulcer. On any day, 15% have an ulcer, often 2 or more, so they're often multiple and they can cause damage in the hands. 15% of ulcers ever will be complicated, needing an amputation or having poor blood flow. 15% or 1 in 6 of our patients will have proven pulmonary arterial hypertension, which is a major cause of death, as is pulmonary fibrosis. If we look, 30% of our patients will have interstitial lung disease or pulmonary fibrosis, and in half of those patients, it's clinically relevant and will actually lead in those patients to a cause of death. So 1 in 6 will have clinically relevant scarring on their lungs. 1 in 6 will have inflammatory arthritis. 1 in 6 will have an overlap with myositis or dermato or polymyositis or scarring in their muscles. And 1 in 6 will have an overlap with another condition that's autoimmune, Sjogren's, causing dry eyes, dry mouth. So when we look, there are many, many features of scleroderma, but we're concentrating today on the lungs. But you can be short of breath as well for pulmonary arterial hypertension. So the scleroderma docs, or the doctors, rheumatologists, and others that follow systemic sclerosis patients have to be aware of so many things that can go on. There's also about 8% will have heart involvement, which could make you short of breath. So when we think of when we would treat patients with scleroderma and pulmonary fibrosis, or before they're scarring on the lungs, scleroderma and interstitial lung disease, which could be inflammation and or scarring, first of all, there aren't very good guidelines. So there is disagreement, mostly agreement, but some disagreement in the literature. And guidelines are based on evidence from experts, as well as from randomized trials and case series of following patients with scleroderma. So first of all, if a person is worsening with their scarring or inflammation at the bases of their lungs, we want to rule out infection. Also, our patients, I said the swallowing tube is almost always involved. So we want to rule out aspiration, because if you're aspirating in your lungs, you will progress your scarring on the lungs. So we want to raise the head of the bed, not eat after supper time for our patients. We want to treat with severe, if you have severe anti-reflux, with drugs that send the food through your swallowing tube, as well as high doses of our proton pump inhibitors, or those drugs like omeprazole, pantoprazole, drugs like that, rabeprazole. We want to dilate the esophagus, the GI doctors, if they have a narrowing, because that would lead to more aspiration if food is getting jammed or stuck. You can have more shortness of breath and worsening if you have a lot of tightness on your chest wall or weakness of your respiratory muscles, your chest wall muscles and your diaphragm that helps your lungs expand. We also want to look to see if the patient has superimposed high pressures in the pulmonary arteries, because even 15% of our patients with scleroderma with scarring on the lungs or pulmonary fibrosis will have pulmonary hypertension as well. So the two complications together are a bad sign for trying to get oxygen to the lungs and trying to be less short of breath, and a bad sign for mortality. And then we will have to look, if we're going to treat, what are the potential benefits, what's our outcome we can achieve for our patients, and what are the risks, like more drugs with side effects, or for our autoimmune treatments or immune suppression treatments, are we going to increase the risk of infection too much in a certain patient or not? So we look at screening these patients, and we want to look at their lung function. So we want to look, are they short of breath or not? What is their physiology? So those breathing tests, the pulmonary function tests, and also what does their imaging look like? The chest x-ray, and at key points, the high resolution CT scan of their lungs, or their chest CAT scan. So we've got to look at all that and take into consideration what's going on. So in general, if the breathing capability of the patient is compromised, so a forced vital capacity, how much air can they blow out on the breathing test? If it's less than 70% of what it should be, so it should be 100% approximately, plus minus 20%. If they have more than 20% of the skin, the scarring changes on their high resolution CAT scan of their lungs, if they have that antibody SCL70 or topoisomerase that increases the likelihood of lung disease, or if they're recent because they might be getting worsening lung capacity over time and leveling off more down the road. So the biggest drop in their going down the stairs of their lung function is really in the more recent patients, but it's often at 7 to 10 years that they actually really compromise lung function, because they're losing at the beginning, losing less aggressively later on. The slope is worse and then it levels a bit, but they still can lose function over time. So those are things that might justify treatment, but no major consensus is important to note. So this is why our patients with scleroderma involvement in the lungs are often followed by a respirologist, or the pulmonologist, the lung doctor, and usually the rheumatologist, in some cases a general internist. But looking together and getting the best ideas and brains together to actually help determine who should be treated, them with what, and when should we change treatment by switching or adding. So when we look, really, if you have moderate or to severe lung disease, we would certainly consider treating. If you're deteriorating and we think it's from scarring on the lungs or inflammation, not from infection, not from aspiration, we might want to think of treating. If you have short disease onset, so that guy, John, the fake patient I presented, but the real hands and the real imaging of a patient, early in disease because you can lose more function earlier. If you have that antibody, if you have worsening lung disease on both breathing tests and or imaging. If you're short of breath, I put a question mark because I think that if you become short of breath, that might be an indication for treatment, but the literature doesn't always agree on that. And the lung biopsy in scleroderma is not going to tell us who should be treated and who shouldn't. So it might help in making a diagnosis or in saying, oh, a person also has superimposed chronic infection. They would be very specific cases. Overall, doing a lung biopsy in a person with scleroderma, if we know they have scleroderma in their lungs, is not helpful in guiding treatment. It's only helpful if we don't know what's going on or if we think there's superimposed infection. then this is a published algorithm that my colleagues, the trainees, and myself have published. And this is what scleroderma doctors, so mostly rheumatologists, not respirologists, said on how they would treat interstitial lung disease. And we think of treatment as getting a person somewhat better, so induction, and then maintenance therapy. So if you think of chemotherapy, sometimes people with chemotherapy have induction, more aggressive, more treatment, higher doses, and then they have maintenance therapy, less aggressive, less doses, less drugs maybe. So for induction, high dose mycophenolate mofetil was agreed upon in about 50%. The other 50% said that they would use cyclophosphamide, sometimes intravenous, sometimes oral. So it's either mycophenolate, then cyclophosphamide if they're worsening, or cyclophosphamide, then mycophenolate if cyclophosphamide doesn't work, and then other immune modulator drugs such as rituximab. But you can see even there, induction, we have 50-50 split on should it be mycophenolate or Cellcept, an immune regulator first, or cyclophosphamide. And the reason it's split is because either drug could work, but cyclophosphamide improves the lungs 1 year of cyclophosphamide on average about what you would find improving the lungs on average with mycophenolate over 2 years. But mycophenolate is safer. Cyclophosphamide is a little bit maybe more effective of 1 year of treatment than compared to 2 years of mycophenolate. For maintenance, mycophenolate is safer, so often lower doses on maintenance, and you can see high agreement. If it doesn't work or isn't tolerated, azathioprine, and if not, cyclophosphamide. Usually we don't use corticosteroids because that can increase other problems in scleroderma, such as kidney crisis or renal crisis. And usually we don't use corticosteroids, prednisone, because it doesn't work. But some people said, oh, always I would give a trial because if it does work in the next month, they're less short of breath. That's a good prognosis. But you can see only 1 in 10 or 11% said always of our experts, occasionally about 1 in 4. So there is a consensus for treatment of interstitial lung disease from the Europeans, and that's been recently published in the Lancet Rheumatology journal, and that's really very similar to our consensus that we did looking at experts from the Scleroderma Clinical Trials Group, experts from our Canadian Scleroderma Research Group, and some European experts as well. So it's very similar to what I've given you there. So if we move on now to the next slide, let me just try here again. There. So if we look at John, our fake patient, and for some of you that came a little bit later, John has relevant interstitial lung disease with active progressive systemic sclerosis or scleroderma. If his lungs are worsening, even if his skin's improving and or if his ability to get air out, his forced vital capacity reduces, ability to get air out of his lungs, we would definitely be treating a patient like that. And why? Because this can be predictive of survival. So this is a graph looking at your decline in your forced vital capacity of greater than 10%, the blue, or your gas exchange, the diffusing capacity. You can see here that in these cases, you will find that the mortality is worse if you are worsening. So if you're dropping by 10% or more, you have higher mortality over the next 100 months, by the way, is several years, but 100 months, or if your diffusing capacity, the gas exchange is dropping by 15% or more. So a decline by 15% and diffusing capacity will increase the risk of dying, or dropping by 10% over 1 year, or I would say in scleroderma, there's data even over 2 years, increases the chance of mortality. Now we have someone writing in chat, so thank you, Barb, looking at 25% of scleroderma patients will get interstitial lung disease. That is true. So is the rheumatology societies, are they having guidelines for screening and treatment and standardizing screening? So there are European guidelines for following systemic sclerosis overall Europe, as well as within the UK, the British guidelines. And interestingly, we don't have Canadian guidelines or American guidelines in systemic sclerosis, but what we do have is who should we screen, and really patients should be screened at least annually for interstitial lung disease, the high-risk patients even every 6 months, and then over time every 1 to 3 years. Because again, if you don't get interstitial lung disease early with your scleroderma, then getting it late is unusual, not unheard of, but unusual. So that's what our guidelines suggest. So our Canadian Scleroderma Research Group, we have statements and we have data to back up our statements that early on patients with diffuse should be screened at least every 6 months for the first year or two, then every year for the first 5 years. If they have limited disease, annually for a while, and then every 1 to 3 years. And we usually screen by pulmonary function tests, the breathing test, but we also listen to the lungs when we don't have COVID. And we also do chest x-rays and CT scans of the lungs in patients that look to us to be at risk. So that's what we do. And so that's an excellent question. Thank you, Barb. Now, these are data from all of Ontario patients with scleroderma from the billing database and the pulmonary function testing and things like that. So these are the survival of patients with scleroderma in Ontario. At the bottom, you're looking at days. So 365 with a 0 on the end would be 10 years. And you can see that we do have patients with scleroderma dying with about a mortality of 1 in 3 at 5 to 10 years. So it is a disease that will kill some of the patients, certainly not all, and our survival has definitely improved by Canadian data from looking out west, Canadian data looking in Montreal, and Canadian data looking at our site in Ontario. So our survival for our patients is improving. But if we move on to the next slide, the survival is even worse if a patient has scleroderma with the lung involvement. So you can see here, instead of having 70, you can see the survival at 1 year, the mortality is reduced, and it's down to, and even the first year, when you get interstitial lung disease, 1 in 5, it's a lethal complication, even in the first year of having your interstitial lung disease diagnosis. So it's very important that we do screen, as Barb asked. And if we look at the changes in survival, or more, actually, I'll frame it the other way. The causes of death in scleroderma have changed over time. So renal crisis, the kidney involvement, is only happening in 15% of our early diffuse patients, only about 3% overall cross-sectionally, because some of them have died of other complications over time, including their kidney crisis. It's about 3% of all our patients, but 15% of our early active diffuse patients. And that used to have a high mortality. Now with ACE inhibitors, it has a lower mortality, but you can see pulmonary arterial hypertension, which occurs in 15% of our patients, and interstitial lung disease, which is clinically relevant in 15% of our patients, are the two main causes of death of scleroderma over the last couple decades. That's what's important for our patients to be diagnosed and treated, because there are higher chances of mortality. Again, not everyone with scleroderma will die of these complications, and not everyone who has these complications will have a rapid progressive decline, but these are what the data show us. Then this is looking at, for the leading causes of death in scleroderma, this is just another way of looking at this, that you can see GI involvement, heart involvement, pulmonary arterial hypertension, all can be causes of death, but you can see the orange is the interstitial lung disease, and you can see that that orange bar is increasing over time. And you might want to ask, why is that happening? And I can tell you, I'm not sure. It might be that patients weren't dying of the other complication, the kidney crisis. It might be because the age of onset of our patients is getting older, and certainly interstitial lung disease and also, interestingly, pulmonary arterial hypertension are worse if you get them older than younger. So it might be something to do with resilience of the lungs, or it might just be our environment is changing. I don't know why that's the case, but I think if you look at that orange, that now the bar would be staying at about that rate, not necessarily increasing, because these are data that in this publication only went up to 2001 because they wanted to follow the patients forwards to look at cause of death over time. So patients do worse with their lung disease and scleroderma if they have lots of interstitial lung disease on their CT scan. If they have damage, meaning scarring, because honeycombing or those holes, the Swiss cheese holes, particularly at the bases of the lungs, you can't repair that. That means that all those air exchanges, like a sponge that's exchanging carbon monoxide for oxygen, that sponge has got big holes in it, bullet holes in it, or someone's cut big holes in it. So you know a sponge can't absorb as well if you don't have as much sponge parenchyma or the tissue. If you have low oxygen, hypoxia, and need oxygen, needing oxygen can help prolong life and help make you feel better, but having low oxygen all the time is bad, obviously. Having superimposed pulmonary hypertension, which is 15% of our lung disease patients will have pulmonary arterial hypertension as well. Cough, we've learned more recently, seems to be active lung disease. So if you have a cough with your scleroderma, you're either a chronic cough all the time, you're either aspirating, so your swallowing tube, you're aspirating or barfing into your lungs. Aspirating into your lungs is bad, or the cough is because you have irritation and inflammation because of inflammation in the lungs or scarring in the lungs. So cough is a bad sign. So we pay attention to that and try to think, if I'm uncertain whether I should treat you or not, and you have stable to slightly worse pulmonary changes, but you have worsening or new cough, I will pay attention to that. If you have severe restrictive lung disease on those breathing tests, or if you're a smoker. So anyone with lung disease of any kind of lung disease, whether it's obstructive, like obstructive lung disease, emphysema, or asthma, or whether it's restricted, like idiopathic pulmonary fibrosis, or scarring, fibrosis, interstitial lung disease from the connective tissue diseases, or any other lung condition, please stop smoking. And pharmacists, as well as your physicians and nurse practitioners, can help you to stop smoking. So stopping smoking is important. Now we're going to switch gears and look at a patient who has rheumatoid arthritis with interstitial lung disease. So again, it's a fake name, but based on a true patient. So Sarah is 74 years old. She has seropositive rheumatoid arthritis, so that positive rheumatoid factor. She might never have had an anti-CCP, another antibody done, because she's had long-standing rheumatoid arthritis. That antibody didn't exist back then, and we didn't need it now for prognosis or for diagnosis. She has damage, so erosions, and you can see her hand has drifted down from damage in these joints, and she has damage in some of these joints as well. And she has nodules. Rheumatoid nodules are uncommon now in rheumatoid arthritis, but certainly are present probably in about 5 to 8% of our patients. She's had rheumatoid arthritis for a long time because she onset her RA, her rheumatoid arthritis, at age 45. So that's like 30 years ago. She was a 5-pack year smoker. So she was a smoker in her 20s, but just a pack a day for 5 years, and fortunately quit. So she quit smoking 50 years ago. She's been on methotrexate. That's our standard treatment for many patients with rheumatoid arthritis at our usual full dose of 25 milligrams once a week, and she's on hydroxychloroquine or Plaquenil. And some of you are now aware of Plaquenil. It's the anti-malarial drug, but because they were looking at it at COVID, at first it was good, but now it doesn't really change the outcome of COVID. But it's safe for our patients to be on the doses we use in rheumatoid arthritis, lupus, and other conditions where we use it every single day. And the doses we use, it doesn't give heart issues. So it is safe, because at first it was great for COVID. We were worried about a shortage. Now it's neutral on COVID, but then people were worried about safety because they used it in 4 times the doses that we use, and with another drug that gives a drug-drug interaction and can give heart issues. So that's not how we use it in rheumatoid or lupus or scleroderma or myositis or Sjogren's. So now Sarah comes in for her every 6-month visit, or in these days it might be a phone call visit because of COVID, but she has new shortness of breath. And in fact, if it's a phone call, her daughter's also on the phone to say, make sure, Mom, you tell your rheumatologist what's going on. Or if it's an in-person visit, her daughter has come with her saying, Mom, make sure you are short of breath, and don't just say you're fine when the first thing we always say, how are you? And people say, fine. But then we go, okay, how really are you? What about your joint pain, your stiffness, your swelling? What about your function? Anything else going on in your life? And it's really not until we get all those questions out do we ever hear about someone saying, well, I'm newly short of breath. And that's why, because it's subtle change over time for most people with rheumatoid lung. So again, these are my patients. You can see Sarah there with her subluxation ulnar drift, so the damage of her hands, a classic rheumatoid hand deformity. You can see on the x-ray all the damage. So it looks like someone got an eraser and smudged the joint line areas together, and a Pac-Man came and bit holes in the joints areas. So there's erosions, joint space narrowing, damage, malalignment, subluxation. And this patient, you can see there's actually rheumatoid nodules in the lungs. So you could be short of breath for rheumatoid arthritis because you have nodules in your lungs, because you have not, in Sarah's case, not on this x-ray, because you have fluid on the lungs, a pericardial effusion from rheumatoid arthritis, or fluid around the heart, pericardial effusions, or because you have interstitial lung disease, or for reasons unrelated. You could be short of breath because you have heart involvement from rheumatoid, very rare, or because you have angina or a heart valve problem. So there's a lot of different reasons. Now we have a great question again. So I said interstitial lung disease usually presents early in scleroderma, late in rheumatoid arthritis, and that it could be caused, interstitial lung disease, by methotrexate. So methotrexate lung is a problem that is very, very rare. It's less than 1% of our rheumatoid arthritis patients, and that's they look like they have pneumonia. They might have fever, they're suddenly short of breath, and both their lungs are filled up looking like pneumonia, inflamed all over their lungs, all over the place. And that is almost like an idiosyncratic, meaning we don't know why, but like an allergic reaction of the lungs, and that to methotrexate. And that is a problem, very uncommon. So at most 1% of people on methotrexate with rheumatoid arthritis will get that, and probably even less. So that's how methotrexate can hurt the lungs. Removing methotrexate from a patient with well-controlled rheumatoid arthritis can worsen their lung disease. And I will talk about that later. So respirologists go, methotrexate is terrible for lungs, get rid of it. And rheumatologists say, methotrexate might be partially treating the lung disease that this patient has. If we remove it, they might worsen. So that's an excellent question. So interstitial lung disease in scleroderma, early onset, but later it's causing the death. And rheumatoid arthritis, usually long-standing rheumatoid arthritis. Again, you can see the changes not as severe in the lungs, or sorry, in the hands of the patient with rheumatoid arthritis. The next picture is an elbow with rheumatoid nodules in it and a cushion of fluid at the elbow. That's where rheumatoid nodules like to hang out, but they can hang out on your heels, on your hands, like where you type on your finger pads or where you hold your pencil. So there are areas like that, but often surfaces that rub. And then this is one of my patients with very, very severe rheumatoid arthritis, where her hand, it's just even so difficult to describe. And this patient could still get dressed, but not buttons. She had a lot of Velcro. She couldn't tie up shoes. It was very difficult to cook meals. So she presented back. She'd been lost to follow-up, losing weight because she couldn't chop vegetables or anything like that. So she wasn't eating as much. Unfortunately, though, that patient could still hold a cigarette, and I told her that she was going to burn her house down because she dropped the cigarette, or burn her clothes because of the inability to hold the cigarette right. And interestingly, that's what made her stop smoking. So that patient with the terrible hands no longer smokes. And every time I see her, we talk about, you're still a non-smoker, good for you, because she had been a long-term smoker. So if we look at how common in our diseases do we see interstitial lung disease? So in 15% of our scleroderma patients, it's clinically relevant. In about 1 in 3 or 30% of our scleroderma patients, it occurs. Now, in this study, this is from a lung clinic. They see it happening more often in patients with interstitial lung disease, having scleroderma. So remember, in that care pulmonary fibrosis, 40% of the patients had connective tissue disease that had interstitial lung disease. So they see that it's involved in scleroderma or rheumatoid more commonly than we see as rheumatologists, because we see our patients who don't have interstitial lung disease as well. So in rheumatoid arthritis, I think it's at most 5 to 8% of patients, and they're usually long-standing, strongly rheumatoid or factor positive, or the other antibody, anti-CCP positive. There's also in lupus, not very common to get interstitial lung disease, usually quite treatable, and a lot of other things can mimic it. So it's probably about 3%. In our Canada-wide lupus group, our Canadian Network for Improved Outcomes in Lupus, or CANIOS, it's about 5% of our patients. In Sjogren's, it's about 10%. But even in some clinic series, up to 30%. And mixed connective tissue disease, a bit higher, maybe 1 in 4, 1 in 5, even 1 in 3. So you can see that it varies in the literature. And so that's why, as rheumatologists, we have to think about it, we have to talk about it, and we have to screen patients who are at high risk, and we have to think about it in our lower risk patients. So we look on exam for patients with, obviously, if you're already blue in your lips, that's kind of late. That means your oxygen's bad. We look for listening on their lungs for those crackles, those Velcro sounds, and every rheumatologist has a stethoscope and knows how to listen and look. But we can look for the loss of angle in their fingers or clubbing, and that is a longer standing sign. But if we see clubbing and the patient has the crackles on the lungs, we will investigate. So clubbing is the loss of angle, and you get splaying here. The fingers look sort of almost bulkier at the end of the fingertips under the nails. So those are some of the things we look for on physical exam. And we would do all these things with Sarah. We would renew her meds. We would see her and follow up sooner. We'd probably refer her to a respirologist, but we would want to determine, why is Sarah, our 74-year-old with rheumatoid since age 45, why is she short of breath? So we hear the crackles. We're going to do a chest x-ray. We'd probably do an oxygen saturation if she's sitting in clinic, and walk her around clinic a bit and read and do it to see if she desaturates, which fortunately Sarah didn't. We do the high resolution CAT scan of her lungs, or CT scan of her lungs, and we would do her breathing test. So we would do all those tests to figure out what's going on with Sarah. So this is a very bad end stage lung. You can see the Swiss cheese or the honeycombing all over the place at the bases, but even at the top and the sides. That is not how we want to diagnose Sarah. So we have some questions that have come in too. Thank you for asking. So someone's asking, is polymyositis, dermatomyositis with anti-Jo1 antibody something that rheumatologists see? Yes. Is it on the radar screen of rheumatologists for having an increased chance of interstitial lung disease? Absolutely yes. In that myositis condition, Jo1 is the highest chance, not the only chance, but the highest chance of interstitial lung disease. So if you're Jo1 positive, that's one of these antibodies, part of the not ANA panel, but the ENA panel. Every rheumatologist with a myositis patient orders that panel. It's available in all the panels that we order the ENA on for Jo1, and we are fully with it. Now, did our patient Sarah go to a cardiologist? Probably not, because she doesn't have retrosternal chest pressure. It's not at rest with mild activity. It's with more moderate activity. Shopping to get the groceries, she's not short of breath, but carrying all the groceries from the car into the house where you have to make a few trips, then she's short of breath. But if we didn't find a reason for her shortness of breath, we would think of sending her to a cardiologist for either a treadmill walking stress test, or more likely, if Sarah has bad feet, like how she has bad hands, you can do a chemical stress test, a thallium or persantine stress test to stress the heart and see if there's poor blood flow in there. So she wouldn't directly go to the cardiologist first. Okay, so just like it was asked already in anticipation, her lung doctor, she has interstitial lung disease. And the first thing the respirologist will tell the rheumatologist is get rid of that methotrexate. So the rheumatologist might stop the methotrexate, or the respirologist says, hey, rheumatologist, get rid of the methotrexate. So as a rheumatologist, I might stop it. I might actually ignore the recommendation. I hope I won't. I hope I'm going to discuss it with the respirologist, the role of methotrexate in helping disease manifestations, not just the joints, but decreasing their cardiovascular risk of things like heart attacks, but also keeping the interstitial lung disease in check. So if we stop methotrexate, it could go crazier. So if we stop methotrexate, we have to give another treatment. So we have this kind of conversation all the time. And this is one of 3 recent studies saying that interstitial lung disease is less apt to occur, and in fact, less apt to progress if the patient is on methotrexate. Now, if we never put them on methotrexate, they might have started with a scar in their lungs already. So that's a different question, a different problem. If you already have bad interstitial lung disease, might I choose a different drug to help you versus you're on methotrexate and you have interstitial lung disease, and maybe now it's worsening, or maybe now you've gotten lung disease. So it is a point of contention, because it's like methotrexate can scar lungs, but that's usually acute inflammation, sudden pneumonia-like picture. Ongoing methotrexate use, but probably does not scar the lungs. But the worst patients with rheumatoid arthritis, like the not super mild that are only on hydroxychloroquine, almost all of them get exposed to methotrexate. And that's why the lung doctors always see the patient on methotrexate and wonder what's going on. So the good thing is we have had a lot of data to help us sort this out. Okay, so treatments that Sarah might receive because her lungs are quite inflamed and they're scarred and she's short of breath. We might indeed give her rituximab and she would be eligible, not because of her lungs. We would find enough joints to make her eligible, because rituximab is not approved for interstitial lung disease, but randomized controlled trials in connective tissue disease can demonstrate, including looking secondarily in RA trials, that it might help improve the lungs. Tocilizumab looks like it could help the lungs in scleroderma. It's approved though in rheumatoid arthritis, so we might consider that. We would absolutely consider using cyclophosphamide because we have data of interstitial lung disease in randomized trials. We might think of nintedanib, that I'll talk about shortly. That is one of the proven drugs in idiopathic pulmonary fibrosis, now with some proven randomized trial of patients, including a subset that had rheumatoid arthritis. So any of the above treatments we might want to consider, or we might even want to consider one of the immune modulators and nintedanib. So we have a lot of options for Sarah. So we can look at sort of some of this lung involvement, and we want to look at scarring on the lungs and inflammation, and we might want to have a drug that might help both, or at least inflammation, and another drug that might help both, but at least helping the laying down of collagen or the scarring. So there are 2 proven anti-fibrotic drugs for idiopathic pulmonary fibrosis, IPF, one of which is proven and approved by Health Canada for connective tissue diseases, including scleroderma, and now also including rheumatoid arthritis, and that's nintedanib. So some of you listening that have idiopathic pulmonary fibrosis might be on either of these 2 drugs, but right now the data are only, the high level data are only in nintedanib. Might there be help from pirfenidone in our patients? Yes, probably, but we don't have the data yet. We have a little bit of data, but not enough to make Health Canada, look and say that that would be approved. So nintedanib, it comes, as you know, in pills. Pirfenidone also comes in pills. And nintedanib, you can have diarrhea, and the frequency of diarrhea causing dose reduction in rheumatoid arthritis and scleroderma patients was the same as the IPF patients. And pirfenidone has only been tested in some patients with scleroderma or things like rheumatoid arthritis, but so far the side effect profile in those patients looks the same as idiopathic pulmonary fibrosis. So in my opinion, the biggest side effect of these drugs is cost. They are very, very expensive. The second thing is these drugs are to slow the worsening of disease. These drugs are not to reverse the inflammation, unfortunately, in our patients. So we use drugs to try to help the inflammation or immune suppress the patients, and that would be like cyclophosphamide, rituximab, tocilizumab, mycophenolate mofetil, drugs like that. So the anti-fibrotics in scleroderma lung disease, there was in pirfenidone an open label study, but unfortunately the randomized controlled trial stopped early, so we don't have enough data, but the open label said it was well tolerated, same sort of side effects as our IPF population. The Scleroderma Lung Study 3 is a randomized trial. It's ongoing. It's enrolling patients. It's not in Canada right now. It's in the US. So it's looking at background mycophenolate mofetil, so CellCept. Everybody's on background usual treatment for interstitial lung disease and scleroderma, and they're randomized to adding pirfenidone or adding the fake placebo. So we will get data from that over time. We don't know the data yet. Now I'm going to switch to nintedanib. The census data was a phase 3 trial randomizing patients with bad scleroderma interstitial lung disease, so not those mild ones, but bad fibrosis or a bad enough pulmonary physiology, pulmonary function. And they were randomized to getting nintedanib or a fake that looked identical, a placebo. The dose was reduced if there was diarrhea. So it was reduced in, I don't know, about 25% or so of patients. And they could be on mycophenolate, that's a CellCept or MMF. They could be on that as background or not. And interestingly, about half the patients were on that background and half weren't. So we have a lot of data, and it was looking over time. And the key endpoint was your looking at that FVC, or that forced vital capacity, which is a standardized endpoint. And you can see less worsening in the lighter green on the drug than on the placebo. And that worsening was probably over time clinically relevant. And I say probably because as a rheumatologist, it's difficult for me to understand what that means, but the respirologist says this is very relevant, that if you lose this much per year over time, that you're going to have a worse problem over time. And you can see that on average, the light green and the dark green worsened. These patients on average worsened. Not every patient, but on average, there was a drop in their forced vital capacity, but the drop was worse in placebo. And by 24 weeks, you can see it was separating the curve. Even at 12 weeks, it was worse on placebo than on the active treatment. When you looked at the subset, half were on mycophenolate mofetil in steady state, half weren't, you see the same thing. And mycophenolate prevented some worsening, and the two drugs together were better than no mycophenolate and placebo. So as a exploratory analysis, two drugs are always better than one drug. And so that is what Health Canada therefore approved. And in most provinces, the provinces will eventually cover the tab, the money that pays for these drugs. So most programs will pick up the cost of the drug for nintedanib, the nintedanib program, until government or public government or private reimbursement occurs. So that's really important to note. And the rheumatologists know the data, but I'll tell you, in most cases, the respirologists really, really understand and know the data. I do because I'm a scleroderma rheumatoid expert, but many rheumatologists aren't scleroderma experts. They know about scleroderma, but they haven't read and critiqued or published in this area. So the respirologist is usually the one making that call. Now, in addition, Sarah, our rheumatoid arthritis patient, this is you can see these are high-level articles, nintedanib for systemic sclerosis. And then the other one, and these are the data, so I'm not going to talk about them too much other than those graphs that I showed. And again, that's exactly out of the study. The side effects were the same as well as you would expect in pulmonary fibrosis, and the endpoints all showed that nintedanib was better than placebo at less worsening over time. And now this is the rest of it. So this is looking at the overall, sorry, now I have dark green as nintedanib. It was light green on the first slide. Sorry, I apologize. But you can see the worsening if you're on mycophenolate mofetil, or if you were on both drugs is the first purple. If you were on nintedanib and mycophenolate mofetil, on average, you worsened less than mycophenolate alone, which was about equal to nintedanib alone. And both of those, you worsened less than that white, which was neither. You got the fake and you weren't on mycophenolate. So this tells us that we can use the two drugs together, mycophenolate mofetil and nintedanib, to get the least amount of worsening. Now, we would like improvement. When I talked about some of the other studies, I talked about improvement. Then these are looking at the side effects, and of course, higher and active treatment than placebo. So our take home from this study is that there was less worsening on nintedanib, and this is similar to the IPF studies, although in IPF, there's worse rate of progression over time. So there was worse on placebo of rate of progression than on nintedanib, because in IPF, people worsen more quickly, it seems, than in our connective tissue diseases. So then this is looking at tocilizumab, which is an open label. We looked at tocilizumab in 2 trials of scleroderma that showed less worsening. But tocilizumab is not currently approved for treatment of interstitial lung disease, whether in this case rheumatoid or in scleroderma, because they actually haven't done the studies in the large double-blind way that looked at lung primarily. But there's hints in rheumatoid arthritis and in scleroderma that tocilizumab can slow down lung disease. So that's a phase 2 randomized controlled trial going on with 3 sites in Canada for tocilizumab added to background therapy for rheumatoid arthritis interstitial lung disease. So what about looking at patients now for progressing interstitial lung disease, such as rheumatoid arthritis, sarcoidosis, unidentifiable, farmer's lung, all those things. So another high-level study that looked at this, and similar inclusion criteria. You couldn't have IPF, and you could have multiple of these other pulmonary fibrosis, including rheumatoid arthritis. You could be on background prednisone under 20 milligrams, and you could be on cyclophosphamide if it was absolutely necessary for your treatment, such as, say, occasionally an inflammatory myositis patient might be on cyclophosphamide. So you can look again here, about half women, half men, whereas rheumatoid arthritis is 80% women. You can see that they had long-standing disease, and they certainly had moderate restrictive lung disease, some severe. And you can see here, if you were on nintedanib, again, you got less worsening than if you were on placebo. And if you were on nintedanib and looked like your CT scan that looked like IPF, you did better than placebo. But if your CT scan looked like just non-specific interstitial pneumonitis instead of usual interstitial pneumonitis, you still got less worsening. And that's important because in IPF, almost all the CT scans look like Swiss cheese. When you have a mixed population of the non-IPF patients, some of whom look like they have IPF but don't, and some of whom have rheumatoid or sarcoid or whatever, you're still getting less progression in either of those CT scan looks. So that's why Health Canada has approved nintedanib, and why you can get it through reimbursement, public eventually, but private, mostly right now. Most of the private insurers cover it, and rheumatoid lung, or in inflammatory myositis lung, or for the others listening, in sarcoid lung, in people that look like they might have a bit of myositis but don't, so they have some antibodies but don't have the full-blown course. If they have bad enough lungs, this drug will be appropriate for them, and over time we'll get data on pirfenidone as well. We don't have enough data yet. And this is the decline again, nintedanib, less worsening than the placebo over a year. And again, this shows the data, and this shows that the rate of decline was helpful in RA patients, in scleroderma patients in this study, mixed connective tissue disease. Always you're saying that it favors nintedanib, but if your N is small, like 7 and 12 patients or 23 and 16, it's not statistically significant. But fortunately, you always want that on the favors nintedanib is where you're getting your point estimate, but the confidence interval around it, if you have a small sample size, might cross to the other side. So in all those subsets, there was benefit. And again, there's benefit if you look like you had the IPF looking lungs or the usual interstitial pneumonitis pattern. And also, again, even if you had other fibrotic patterns, but less people in the second group and a wider certainty or 95% confidence interval around it. And again, looking at the adverse events, similar, where some people are going to get diarrhea, and 1 in 4 or occasionally 1 in 3 are going to have to down their dose. And so if you lowered your dose or not in the scleroderma study, and in this case now in the other study of IPF with nintedanib, you could still get the benefit, fortunately, just like in IPF patients. So our take home was that nintedanib slowed disease progression as measured by that forced vital capacity, and that it was fairly well tolerated. And this is why we can now use this drug when appropriate for other connective tissue diseases like lupus, scleroderma, myositis, but more commonly than those, rheumatoid arthritis. And we could already use it a year before. We had the results in scleroderma patients who had clinically relevant interstitial lung disease who were worsening or had bad honeycombing or failing the current therapy. So these are the things that we think about. If you have interstitial lung disease with autoimmune features, you might almost have myositis, almost have Sjogren's. So they don't meet the criteria for their connective tissue disease, but they have the antibodies. And I do see referrals, a handful every year, of patients with a positive rheumatoid factor and or anti-CCP antibody that look like they don't have IPF, but they have interstitial lung disease. And they say to me, is this a patient with rheumatoid or not? I see patients as well with that anti-Jo1, that do they have myositis or not? The CK is just above the upper limit of normal. They don't have weakness. They don't have rash. They don't have EMG, nerve conduction, or muscle studies of muscle inflammation or irritation. So I see these patients every year because I have an interest in connective tissue disease, and because I do have a finger on the pulse of interstitial lung disease in my patients because of my research and clinical interest. So rheumatologists do see these patients to figure out, can we treat them differently or not? So this is a case. This would be a patient who has never been a smoker. She has cough, and she's had shortness of breath for when she goes out for her longer walks or mild runs. She has shortness of breath almost the last year. She has restrictive lung disease, and she has a little bit going on the CT of her lungs, not those big Swiss cheese holes. She has an ANA being positive, as do many healthy individuals. About 1 in 3 women in Canada have a positive ANA. So if your ANA is positive, we go, whose isn't? It's commonly positive, but she has part of that ENA, the anti-Ro positive, and she does have Raynaud's that she got a few years ago, the hands going white in the cold. So there is a study looking at pirfenidone in these patients, unclassifiable progressive fibrosing lung disease, and basically it shows that pirfenidone could be more helpful, but their primary endpoint wasn't met. An exploratory endpoint was met because they just didn't enroll enough patients, so they finally stopped the study and analyzed it. So does pirfenidone work in these patients? Probably yes. Is pirfenidone approved for these patients? No, not yet. They have to do a bigger, larger study. So again, we come to these unidentifiable patients, and sometimes with a biopsy, they're identifiable like allergic alveolitis, or on biopsy, they're not identifiable. So we do have patients like that, and we now can use some treatments, maybe immune suppression, maybe not, but we can use the anti-fibrotic type treatments like you would use an IPF, idiopathic pulmonary fibrosis, if it's appropriate. So again, we don't just treat everybody with drugs like this. You want to know, is it bad enough? Are they worsening? Do we think they're going to progress? You want to understand where they're at. So you might follow them over time for a while. And these patients are always a respirologist, the lung doctor, the pulmonary doctor, with or without a rheumatologist following, but a rheumatologist certainly giving their expert opinion in this kind of patient. And so these are the take-home messages from that study. So, and again, the side effect profile was the liver enzymes and nausea, about the same as you would expect on pirfenidone as in the idiopathic pulmonary fibrosis patients. This is just showing the home respirology meter that they looked at, the blowing the machine at home to look. And this is just showing that you're always favoring the pirfenidone over the other group in most things, all except for 2 of these subset analyses. So you wouldn't use this outcome if you did a bigger trial because it wasn't a great outcome measure, but they were trialing it. So we're back to John. What would we do? That was our scleroderma guy with the lung disease. Any of these treatments might be appropriate. So if he's worsening on mycophenolate, you might add nintedanib. You might add nintedanib and switch to cyclo. You might not add nintedanib and switch to cyclo, etc. You have a lot of options, including adding nintedanib with proof or switching to cyclophosphamide with a lot of clinical experience. For Sarah, she had that bad pulmonary change on her lungs after years, decades of rheumatoid arthritis. And for her, we would probably consider lots of options. We would probably switch her to rituximab, maybe maintaining rituximab, maybe getting or maintaining methotrexate, maybe getting rid of it. We could maintain or get rid of methotrexate and give her tocilizumab. We would get rid of methotrexate if we gave her cyclophosphamide because we don't put those 2 immune suppressants together. And or we could consider any of those above options and adding nintedanib or keeping methotrexate and adding nintedanib. So we have a lot of now anecdotal and somewhat proven options for either of those two patients. And so what about shared care? I want to spend a couple minutes, and then I do want to open it for questions. It is really important if you have a complex disease with a very significant lung complication, so an autoimmune disease that a rheumatologist sees, and you have a lung complication that we think is relevant, shared care is really important. So shared care might be going to a clinic where there's a respirologist and a rheumatologist. That occurs in Hamilton, it occurs in Toronto, it occurs in Calgary. So it doesn't occur everywhere, it probably occurs in other sites. Or you've got a respirologist that the rheumatologist uses a lot, or a respirologist that does interstitial lung disease quite frequently, of whom there's about 20 or more of these interstitial lung disease respirologists all over the country. Or you have a respirologist that knows all about IPF, idiopathic pulmonary fibrosis, that works with a rheumatologist. So shared care models can look quite unique, but why do we need shared care? It gives the best care for two different areas: the rheumatology area of autoimmunity and the organ systems involved for the rheumatology patients, and the significant lung involvement. So that is important. And so I think shared care, and by the way, conversation is important, and communication. The patient, the primary care, the respirologist, the rheumatologist, everybody has to talk to each other, or that patient doesn't get the most optimal care. So conversation and letting everyone know what's going on is super important. So what have we talked about? We've talked about interstitial lung disease that might or might not look like idiopathic pulmonary fibrosis in our patients with scleroderma and rheumatoid arthritis and other connective tissue diseases, or possible connective tissue diseases like that one that had the antibodies, that last case, but she didn't necessarily meet criteria for inflammatory myositis. We've talked about hope for these patients. We've talked about now proven treatments, Health Canada indicated treatments, treatments that are very expensive and that coverage is important. And we've talked about if they have low oxygen, they need oxygen. I haven't in this lecture, you will hear others, I haven't talked about exercise, but exercising our patients who are short of breath with interstitial lung disease is really important, even if they're short of breath doing it, because that in and of itself can improve their quality of life, improve their shortness of breath, and might prolong survival. So I haven't talked about it here. We've talked about immune suppression as well as anti-fibrosis, anti-fibrotic treatment. And we've talked about shared care, and that overall now there is more hope for our patients of prolonging survival and or improving their quality of life by the various mechanisms and functions between treatment and looking at the respirologist and the rheumatologist opinion. We also now have one of which probably will be many other drugs indicated for the scarring on the lungs, the interstitial lung disease or the pulmonary fibrosis or the non-specific interstitial pneumonitis or the usual interstitial pneumonitis that's occurring in my patients with connective tissue diseases. So with that, this has been a long lecture for you, so I thank you for attending, and I'd like to open it up to questions via the chat or the Q&A, and I'd also like to open it up for closing remarks from Sharon. So with that, Sharon, and one more slide after this, Sharon, because thank you to our sponsors. We'll get to that next slide. Because a program like this to be recorded and posted on the net, I probably have to get out of this to get to the sponsors because these were sort of backup or hidden slides. Sharon, are you able to find the sponsor slide? Because it's at the very end. And Sharon, I think you're on mute. Sharon has a list of sponsors that I assume are Boehringer Ingelheim, possibly Roche.
So I will
So sorry about that. I think all the hidden slides are not for the group to see, but that at the very end of all that, you probably have the
Okay.
responses.
I'm just going to thank them officially. So I want to thank Axion, who hosted the session for us, TELUS, Repeatex, Boehringer Ingelheim Canada, Roche Canada, they were our main sponsors. And we also had some smaller sponsors like Telford, SNAP, and the Respirologist Home Care Solution. So I want to thank them all because, as Janet said, without their generous support, we couldn't have had our event today. So I want to acknowledge that. And okay, so the session is open for any questions that you would like to ask Dr. Pope. We're open.
And while people are thinking of questions or listening, Sharon, for the journey, because the IPF patient is, I think, somewhat even more lost at first, because our connective tissue disease patients often have their connective tissue disease with a diagnosis before they have their lung disease. But even on my patients' kind of journey, they will say it took a really long time to get my diagnosis, particularly the rarer connective tissue diseases. So they share the same frustrations, I think, as the IPF patients. And on their journey, they'll say, how come I had to move cities or get a new specialist or have a new, respirologist or rheumatologist to even listen to my lungs? Well, the respirologists do listen to lungs, but a new rheumatologist. So I think it just shows that although I think there's a very good standard of care in Canada for rheumatologists, we do have to remember other organs. We're not just joint doctors. We're not just autoimmune antibody doctors, but that we do try to be holistic. And to me, I think examination of the joints, the skin, but the lungs is every patient at every visit. The skin is for scleroderma or for the rashes of lupus dermatomyositis, not necessarily the skin on your RA patients. But we have to really understand that these diseases, if we're going to treat someone holistically, if I detect something earlier, like hearing crackles on the lungs, I will investigate whether that patient is short of breath or not. I might follow more carefully with lung function or other imaging if they're not short of breath, but I'm going to follow them more. I might treat, obviously, if they are short of breath, or change their treatment if they have worsening or new shortness of breath. So I think that the frustration of why did it take so long to get me where I am? What could have been prevented? Should I have been treated earlier? Is common in the connective tissue disease patients, not just those with lung involvement, but having their connective tissue disease as well, because these are mostly rare or very uncommon conditions that I've talked about. So I think for the people listening with IPF, that shared journey of why can't we do it sooner and earlier is shared by patients with the rheumatic diseases as well, often, not always.
I think it's a matter of knowledge transfer, because not everyone, you're very rare in my path and with rheumatologists that you actually understand both sides of it. Most rheumatologists will only, as you said, look at the joints and diseases and never think about your lung. I think that's one of the reasons why the Canadian Pulmonary Fibrosis Foundation wants to invite speakers like you and try to get others to come on and sort of learn about it, because as most of the respirologists will say, the ILD respirologists, a regular rheumatologist might only see one patient of this kind in their whole entire career, right? But the thing is, it's good to get the awareness out to so that at least they can start thinking about it and say, oh, I might need to make a referral, right? Just on the safe side. We're not saying that every patient will be needing one, but just like you said, it's good for them to think about it, to say, well, maybe this is a patient I need to refer to, and maybe this is something I need to consult with, right? Because you're very rare and unusual that you actually see a lot of these patients, whereas as I've learned from the rheumatologists themselves, they only see sort of just the typical rheumatologist ailments, right? So it's not a combination that they would have your knowledge of in depth like you have.
Right. And just like rheumatoid arthritis is common, 1 in 100. So most rheumatologists have many, many patients like that. But clinically relevant inflammation or scarring, pulmonary fibrosis of our RA patients might only be one patient a year, maybe two patients a year max, maybe one every 3 years, depending on the practice size, and maybe 3 to 8 or 10 or 15% of their entire RA population over the decades they followed them. For scleroderma, they do better, but they only see a hand of screening the lungs, but they only see a handful. Our usual rheumatologist in Canada only sees 8 unique scleroderma patients. I see many, many hundreds, like 500, because I have a research and a clinical interest in that area. So if you only have 8 patients and lung disease is common, 3 of them will have their interstitial lung disease, but only half of that, 1.5 patients, might be clinically relevant. That's 1 or 2 of their patients. So you start going like that and they go, well, I just don't even think of lung disease until they're really short of breath. So I think you're fully right that just the awareness that to be holistic, to understand other organ complications, you don't have to know how to treat it. You just have to have an awareness, which gets to screening and or referrals where appropriate, and then finding that respirologist if you're in a small community that you like, that if you're a rheumatologist, you like, there's a good communication pathway, they're open to seeing your patients, and all those things you also learn from each other, which can only help the patient.
That's one of the reasons why the Fibrosis Foundation want to create these tools, like these sort of check sheets, so that patients themselves can download it and take it to the rheumatologist and say, gosh, you know, like I have this. Do you think you can help me to explore to see if I might be going towards this directions of, pulmonary fibrosis? And so those are things, because I think that most rheumatologists will say, gosh, there's so many things I need to know. And if I only see 8 patients in my whole career, that might be sort of low on my list of to-do things. But if a patient came in and sort of show me this list, then, most likely they go, okay, well, let's go through it and do that. So again, we try to tell patients that, you have to self-advocate for yourself and to be educated and to say to your rheumatologist, like, can we just look at this? Because obviously I'm exhibiting some of these symptoms. Maybe, I'm not there yet, but let's keep an eye on it.
Right, exactly. And I think that's where, on the scleroderma side of things, for pulmonary arterial hypertension, also a #1 cause of death in our patients who will die of their scleroderma. Not all will die. Pulmonary fibrosis is also the #1. They're equal. And so having a checklist of please screen me for my lungs really is important. And there's been a lot of advocacy from networks. So the Scleroderma Society of Canada, from SPIN, which is the Scleroderma Patient Intervention Network on the internet. There's been good advocacy saying, please bring this to your specialist, because again, not everyone's going to have a specialist that sees dozens and dozens and dozens of patients like you if you're unfortunate enough to have a rare disease. And this isn't asthma, a common disease that can even be not fully adequately treated in some patients. So we sort of think, okay, a rare complication of a rare disease, or a common complication of a rare disease, or a rare complication of a common disease, it's very difficult for people to be expert at. So I fully agree that your best advocate is you yourself as a patient and or your family. Bring your spouse or your kid or your best friend when we're not in COVID time, or put them on the phone if we're in a COVID phone call time. Yeah. We do have a question that's come in from Arnold and Lois. So husband. So Arnold was diagnosed with idiopathic pulmonary fibrosis and has had eczema, so dry skin. So antibody tests that might or might not be needed. So eczema would be unrelated to the pulmonary fibrosis. Usually the treatments of pulmonary fibrosis shouldn't make your skin worse, although some treatments dry out skin. It's not usually classically the pirfenidone or the nintedanib. So there wouldn't need to be an antibody test. But if we turned it around for teaching purposes and said, which Arnold doesn't have, but say if there was always a rash in the sun, that not your skin's irritated or burns easily, but a rash in the sun with scarring on the lungs, we would actually investigate that. So that would be a different way from an educational perspective, but no antibody tests need to be needed for that. And then there's a hand up. Yes, please. I don't know, can Thelma speak, or does she have to type?
She can ask the question. Just type it out.
Type it out in the Q&A or the chat. because I'm not sure we know how to unmute. Or there might be on the very bottom, if you scroll around with your little cursor, where there's a video, there's also that mute sign, and you could just click on that. I think that'll allow you to speak. So for me, it's my bottom left, but I'm a Mac and I'm set up this way. So you can just scroll around the edges of your Zoom that you see. And if you find that little mute sign and click on it with anything, you just point and click, you should be able to speak, Thelma. Because I realize sometimes it's hard to type it. Okay, Tina's asking, oh, there's only chat capabilities in the session. So sorry, because again, we can't, if we have everybody, we don't have, but if everyone was able to unmute, we usually have the kid screaming, the dog barking, and or the phone ringing. Oh, wait, that's my house. Quiet today. No dog. I have a bird that barks like a dog or meows like a cat.
Your question, or if you like, you can email me afterwards and I can ask Dr. Pope for you. It's Sharon@cpff.ca. So if you have questions, you could just do that, and I'd be happy to ask her. So I put that into the chat line, and everybody could see that.
Great. And thank you everyone for your participation. And just to give a heads up, there's a lot of these coming, some very specialized, although for lay people that are have a loved one or themselves suffering from conditions that would be important in pulmonary fibrosis. So I do invite you to look. There's going to be a whole month of breathing better with all this going on.
Yeah. Okay, well, thank you everyone. Take care.